So we also understand that QCI is conceptualizing a hospital grading framework. Would you like to throw some light on that?
See, this grading framework, quality means excellence. It means continuous improvement. How, when we started this, we were unclear. We were interacting with all of you. Now I see how Japan became number one in quality. Similar opportunity in healthcare is available now. This is a Atmanirbhar quality movement. This is the grading has the objective or hope that it can become a social movement in healthcare. Towards this, we are interacting with many of you. Like previously mentioned, we want this grading to be a continual improvement program, and also it needs to solve some of the problems in the intricate areas, say between the payer, clinician and provider. There are a lot of gaps. As a result, the cost of compliance is going up. How can we take a problem? How can grading provide the trust and transparency? How we can also provide a data platform. In the age of platform, how can I develop a platform like a UPI where best practices can be shared, where everybody keeps improving, looking at others. This can be one of the state-of-art leading platform. I don't want to compare this grading to what is happening in hotels or what MMT and other grading. We want to make this like an Indian social movement where everybody looks up to the leader and try to beat the leader, and through this process, India sets its own standard in healthcare.
Thank you so much, sir. Thank you. I come to Dr. Panigrahi. Doctor has been a true doyen of embedding quality in Indian healthcare. Dr. Fortis has been a pioneer, through the operating system, through the launch of, formally publishing outcomes in association with ICHOM. And I think that's a significant move to really embedding global best practices in clinical pathways. What's been the journey like, doctor? And what is your prescription to healthcare providers across the spectrum in terms of really getting this into reality for all of them? And which specialties would you prioritize and take this to scale?
Thank you, Kaiwan. First, I'd like to thank FICCI and Dr. Harsh Mahajan and Varun for setting up an excellent program. And the best part I liked was that you had my guru to start off, Dr. Pratap Reddy, because without him, healthcare wouldn't have been what we are today. So I think so I pay my regards to him. And Taiwan, I think so this is a journey that started way back in 2012 when it was just by chance that Professor Michael Porter's that he had created the ICHOM. Because his thing, if you look at the Harvard Business Reviews and all that, he used to mention that the American healthcare costs are going over 18% of GDP. It's not sustainable. So he started looking at what's happening. And then when he started looking at different hospitals, they have the different ways of looking at their outcomes. So there was no standardized sets. So he set up something called the International Consortium for Health Outcome Measurements in 2012. And he said, let's start having standard sets. So that we compare apples to apples, whether it's say a Manipal hospital or Fortis hospital or Apollo hospital, the same standards will be, sets will be. So it was clinical outcome, the patient health status, clinical outcomes. The most important part was the patient-reported outcome measures, because what he felt was that healthcare has become very episodic. I come to Dr. Varun Khanna for a knee replacement, he does it, and then after that, bye-bye. What happens to me after 6 months, 1 year? I may be having other comorbid conditions like a diabetes, like hypertension, but those are not taken care. He has repaired his knee, I'm walking around, that's fine. But that is healthcare in his episode. So what he said is that let's look at it longitudinally. So this is where the thing came up, and it is very fortunate that 2 Indian healthcare players were involved in it. The first standard set would not work, coronary artery disease, low back pain, nuclear prostate cancer, and cataract. So for CAD, the Fortis was incorporated, and for cataract, Arvind. So just as a very proud moment for India is that most of the standard sets for coronary artery disease and cataract were from India. And so it was broken up and it was piloted in, not saying Dr. Rajiv Singh, in escorts in 2012. It was piloted in that 2012-13. And in November 2013, it was rolled out at Harvard Business School. And as I speak today, 58 standard sets have been built. So it captures the health status, the outcomes, and most important is the patient-reported outcome measures. So we incorporated that. We said that in India we don't have that, but let us be the first movers because there's a huge trust deficit out there in the market, especially with the private players. That we just look at the EBITDA and look at our top lines. But what is the value that we are giving to the public? So some objective parameters need to be put in place. So these are the standard sets that we started capturing first for coronary artery disease, the CBG and PTCA. We started looking at our 1 year graft survival for kidney transplant. You will see a lot of kidney transplants are being done. But how many of us are calculating did the graft survive for 1 year? We do a knee replacement. Fine, but when you feel the PROMS factors, the Oxford Knee Score, that means the functional status of the patient. After the surgery is over, is the patient able to, he or she able to walk properly? Because you have replacement for two reasons. One is too much of pain where it's unbearable or you're unable to walk. So for these two reasons, you come for a knee replacement. But if you have the surgery and you're unable to be a mobile person, it is very unfair. For coronary arteries, again, same thing. The outcomes are captured. And then also the patient reported outcomes. So after the patient goes after a CBG or a PTCA, is he functionally cardiac-wise proper or not? If these outcomes are captured, sometimes you capture things from before they go from bad to worse. The PROMs will immediately highlight to the treating clinician that something is not right, please come and check. And data never lies. What I'm saying to say is that if you start capturing data, it is self-improvement, it is the bar. I'm giving a small example. For example, CABG. The gold standard is about 77% should have an internal mammary graft on the LAD because LAD is the most important vessel of the heart. When we started capturing it, most of the hospitals there were a couple of hospitals which were in the late 50s. We didn't do anything, but every month this data has to go. And all clinicians are smart because they know what's the normal practice should be. And they saw an improvement. And as I speak today, our network, if you go to Photos Network, the website, we've been publishing from 2016. And it is that we are a report of 85% lima grafts. Then simple things like someone goes for angioplasty, who's having normal kidney function, he or she should not have renal damage. Should not go for renal replacement therapy. So these things are captured. So these things are captured means that you are giving the patient, the public out there, a true picture of what you are doing. So I think that these are some things which you have to start looking at because the public at large need to know. And most important is our insurance penetration is increasing and it's going to go further and further down. So what I say is that the insurance providers also need to have a proper objective way of looking at how the patients to the hospitals are referring to are being looked at. And I think so my urge is that, ma'am is here, is that Ayushman Bharat is a brilliant scheme. But in August 2018 when the Ayushman Bharat was launched, the day after that, Mr. Indu Bhushan was the first CEO. He had called many of us to the Viman Bhavan. He did make a mention that is the start, we want your help. And sometime down the line, they'll be looking at the outcomes also. He did make a mention. And he did another mention he mentioned was that all these schemes will be subsumed into one scheme, the CGHS, ECHS, all the comment. So that's something down the line. But the quality part, so what I'm saying is that what we are talking in India, I'm looking at the Bharat outside the metros. So some standard format should be, I think this is something that Harsh, I think so we should be looking at. Some standard formats, whether for lap poly or hysterectomy or knee replacement, whatever it is, which can be implemented at Bharat level hospitals, not for India level, the metro levels, and have a digital format going to have a huge laundry list to make it cumbersome for the small hospital out in the Bharat. We start looking at this.
Thank you so much, sir. Thank you. Dr. Sipal, Apollo was the first JCI accredited